It's a great pleasure to be speaking to you today. Today I'm going to be discussing sugar and why we should be limiting its consumption in the context of COVID. I'll be talking first about the rise in metabolic diseases over the past few decades and about the correlation with COVID-19 outcomes. I'll then briefly touch upon the supposed physiological mechanisms behind these links, and finally I'll be focusing on why and how we should be tackling sugar restriction, on which topic I would most welcome your questions. Please feel free to write them in the chat and I'll do my best to answer them. In addition, if you'd like to contact me directly, my email address is on the screen and I'll display it again at the end. I'd like to start by summarising the global burdens of obesity and type 2 diabetes. According to the World Health Organization, as of 2016, worldwide obesity had nearly tripled since 1975. 39% of the global population is overweight and 13% obese. Together, that's more than half the world's population that's overweight. These numbers are staggering. On both maps here, lighter colours represent lower BMI and darker colours represent higher BMI. Interestingly, obesity can also be represented on a graph as correlating with GDP per capita. As you'll see, this map shows a roughly linear trend on a logarithmic scale. Similarly, the prevalence of diabetes has increased steadily over the past 30 years and currently stands at approximately 500 million. This is a particular problem because obesity is a cornerstone of the metabolic syndrome, which is associated not only with type 2 diabetes, but cardiovascular disease, cancer, and COVID-19. Here, you can see the association between a number of metabolic diseases and the hazard ratio for COVID-19 death. This data was reported in a study in Nature, which looked at the primary care records of 17 million adults, which were linked to just under 11,000 COVID-19 related deaths. I've included here diseases directly related to the metabolic syndrome, as well as those which relate to the secondary consequences of overweight and obesity, which include orthopedic problems, sleep apnea, gallstones, and depression. I'm now going to talk a little bit about the physiological and pathophysiological mechanisms linking fructose consumption to poor disease outcomes in COVID-19. In this diagram, you can see how it is posited that the gene coding for the sterol regulatory element binding protein is upregulated by fructose consumption, particularly in hepatocytes, via the liver X receptor, and that this causes inflammation via the nuclear factor kappa B. Similarly, via the primary immune response, nuclear factor kappa B is increased by coronavirus infection. The two factors brought together can lead to a cytokine storm. It has been shown in addition that fructose reprograms cellular metabolic pathways to favour oxidative metabolism, which is required to support inflammatory cytokine production. We know that this is particularly bad for people who are obese, in addition to fructose consumption, because adipose tissue itself releases pro-inflammatory cytokines, such as tumor necrosis factor alpha and interleukin-6, and reduces production of adiponectin, all of which contribute to hyperinflammation. I'd now like to discuss a bit about why and how sugar restriction should take place in hospitals, and would welcome your comments and questions on these as discussion points. I'll start with why. Firstly, and perhaps most importantly in the current circumstances, the research cited shows that reducing fructose consumption can have an impact on acute inflammation. It is particularly important to note that it is acute inflammation that has been studied, as this implies there may be a beneficial effect in the short term. In the context of hospitalized patients, this could have an impact on the length of hospital stay, the severity of disease, and mortality. Outside the hospital setting, it could in addition impact on virus transmission, in this case reception, the primary immune response, and admission to hospital. Reduced inflammation in the short and long term may have an effect on hospitalized patients recovering from other diseases more quickly. Although patients are typically only hospitalized for a relatively short length of time, forming the habit of reduced fructose consumption would encourage patients to continue to do so after being discharged. This would then lead to the long-term benefits of reduced risk and severity of metabolic syndrome and associated diseases. Finally, hospital food should set the example for society. Reducing fructose served in hospital food could influence how those who aren't hospitalized eat. This last reason is interlinked with encouraging staff to reduce fructose consumption. There could be many different ways in which a sugar restriction or ban is implemented in a hospital setting. I'll give a few examples of where it has been done before, and then describe some possible methods of implementing such a policy. The nationwide Children's Hospital in Columbus, Ohio, banned all sugar-sweetened beverage consumption for patients and staff. They included in this definition soft drinks, fruit drinks, sports drinks, energy drinks, and anything else with added sugar of any form. They found that their beverage revenues increased over this period, with sales of milk, coffee, and water increased, reaffirming the success of this experience. The University of California, San Francisco implemented a university and hospital sugar-sweetened beverage ban, in particular aimed at staff. Over 10 months, there was a significant decrease in both the volume of fructose-containing beverage consumed and also of waist circumference in the study participants. This is a bit more of a busy slide. I've listed here several national or multinational organisations which have published recommendations on reduced sugar intake. A few of them in particular are worth noting. Public Health England has listed several areas for action. These include reducing and rebalancing the number and type of promotions in all retail outlets, including supermarkets and convenience stores, as well as restaurants, cafes, and takeaways. Reducing opportunities to market and advertise high sugar food and drink products to children and adults across media. Reducing sugar itself in food and drink products. Increasing the price of high sugar products by 10 to 20% using a tax or levy. Ensuring the provision and sale of healthier food in hospitals, leisure centres, and other national and local government institutions. And raising awareness around sugar levels in the diet with the public, health professionals, employers, and the food industry. The European Commission has recommended 3 types of policy. Those that restrict or eliminate choice, such as bans on the sale of high sugar items in school. Those that guide choice through disincentive, such as tax. And those that enable choice, through measures including increasing availability and affordability of fresh fruit and vegetables. And finally, the scientific report of the American Dietary Guidelines Advisory Committee has recommended reducing the amount of added sugars in the diet through either changes in consumer behaviour, in how food is produced and sold, or through food policy. I'm now going to talk through a few ways in which sugar restriction could be implemented in the hospital setting. On this slide, there are some recommendations of key steps in implementing a sugar-sweetened beverage ban from the Ohio hospital whose experience I described earlier on. There are 4 factors which are recommended by a review on NHS hospital food for successfully delivering first-rate hospital meals. They are, firstly, to adopt what they call a whole hospital approach, by which they mean integrating food into the life of the hospital, having visitors and staff eating in the same canteen, with food considered part of a patient's care. Secondly, the chief executive of the hospital should be leading the change and understand the value of good food. Thirdly, the changes should incorporate things which patients and staff care about, such as the quality of the food and the environment in which it is served. And lastly, there should be a multidisciplinary team working towards these changes, to include at least catering, dietitians, and nurses, and to ensure that both patients and staff have access to good quality food all the time. Granular examples of how to reduce sugar in practice might include replacing desserts with starters, limiting portions and packaged snacks to maximum of 5 grams of free sugar, and removing all sugar-sweetened beverages, including fruit juices. In terms of going about implementing these changes, it's helpful to ensure buy-in from employees, patients, and families before instituting a ban. In addition, displaying nutrition facts around the hospital and canteen areas can encourage healthy choices. Similarly, indicating healthier items using a traffic light system has a similar effect. Before and during the institution of a ban, marketing using email, meetings, flyers and posters, education tables, and handouts with meals, as well as media stories and social media stories, can assist with understanding and approval of this sort of measure. And in general, replacing high sugar items with healthier alternatives is the best way forward. I'll finish by saying that we are now more than halfway through the United Nations Decade of Action on Nutrition. Whilst public policy shows a trend towards sugar reduction, practice has not yet caught up. Thank you very much again for listening, and I would most welcome any questions you might have.